Once the initial planning phases have successfully been completed and we have our key stakeholder buy-in, we need to think about revising our dosing policies. Do we need to have any exclusion for AUC-based dosing? I have some key groups that we might want to exclude listed on the slide, though this may vary depending on the AUC methods that are being employed. In your dosing protocols, providing some guidance on organisms and MICs will be helpful, as Tom discussed. I think this will likely be a frequently asked question based on our experience. Remember, when we're referring to AUC, we're really talking about that AUC to MIC ratio, but seeing most Staph aureus isolates have an MIC of 1 or less, that denominator doesn't really come into play for the most part. If the MIC ends up being less than 1, as Tom discussed, don't adjust your AUC goal. There's just not any evidence for doing that yet. However, if it's above 1, you may want to provide some guidance on considering alternative therapy, particularly in that patient that's failing to respond to vancomycin. But the big question is, what about non-Staph aureus isolates? Most of our evidence for AUC to MIC dosing for Vanco comes from Staph aureus bacteremia. That said, there are some preliminary data suggesting these AUC targets for efficacy are similar in enterococci. Plus, Staph aureus is one of the most virulent organisms we encounter. So if our AUC goal of 400 to 600 is appropriate for these severe Staph aureus bacteremias, it would likely be appropriate for other less virulent gram-positive organisms as well. But again, there's limited data. So this is just something that you have to make a decision at your institution, risk versus benefit. But remember, troughs of 15 to 20 have always been a surrogate for exceeding that AUC minimum of 400 anyway. So take that with a grain of salt. Additional dosing policy updates will likely include guidance on choosing the right model with within your Bayesian platform, particularly if you purchase multiple. For example, maybe you purchase a standard model, a complex or critically ill model, and an obese model. What patient populations do you apply these to? You want to have some standard processes in place so that the dosing is consistent across clinicians. As you heard Tom discuss, the updated guidelines recommend 2-level PK using Bayesian methods, but can you broadly implement this for all patients at your institution? I think for many, including where I've practiced, 2 levels for all patients certainly can be challenging. So what if patients go home on vancomycin? How do we continue their therapy? That's another question we asked. Hopefully, for some of those that are on this webinar, there's going to be access to Bayesian dosing on the outpatient side. But if not, I've generally recommended that if the patient has a therapeutic AUC at a given trough value, that same trough value be targeted on the outpatient side, though it does get tricky if patients' renal functions or dosing intervals change. So just having some guidance there is helpful, and is something, a point of education for your clinicians that are dosing.